welcome to the new episode of the JCMC interview series. Today we are with Jakob Højlund from Hvidovre Hospital in Denmark. So welcome, Jakob.
Thank you, Dr. Introna, and thank you to the Journal of Clinical Monitoring for selecting our study for this presentation. I've been looking forward to it.
Today we are going to talk about a new study that came out in our journal a few weeks ago. It is the Peripheral Perfusion Index discriminates hemodynamic responses to induction of general anesthesia. You will find also the link in the platforms we are going to use to share our video and our audio. So I would start with the first question with you, Jakob. I would like to ask you in brief if you can tell us what this study is about.
Yes. We conducted this prospective observational study of 107 patients where we looked at the induction period of general anesthesia. The main parameter we wanted to examine was the Peripheral Perfusion Index, or the PPI for short. The Peripheral Perfusion Index, it's obtained non-invasively by photoplethysmography, like your normal pulse oximetry finger clamp. And basically, it's the ratio of pulsatile to non-pulsatile signal attenuation, or more plainly, it's how much of the absorbed red light is absorbed by a pulsatile motion. For instance, a PPI of 2 would mean that the pulsatile absorption is 2% relative to the non-pulsatile absorption of light. So, and the pulse oximetry device uses this to look at what it thinks is the arterial signal, of course, because it wants to look at the saturation of the arterial blood. So it's kind of inherent to photoplethysmography. Yeah, what we did was we wanted to look at the changes of the PPI and also mean arterial pressure and stroke volume. And we looked at it, of course, at baseline before induction and then 2 minutes after induction. And we wanted to see how did these relative changes compare, and could we elucidate something from the changes in the PPI about the changes in the systemic hemodynamics. What we did was we stratified the patients into quartiles based on how the PPI responded to induction. So we had the said how much does the PPI increase or decrease 2 minutes after induction, and then we made this as a stratification parameter, and then we looked at the other parameters as mean arterial pressure, cardiac stroke volume, to see could the changes in the PPI say something about the global hemodynamic response. Stroke volume was calculated by a LITCO monitor using in a little bit below half of the patient had an arterial catheter, and then we just put on the LITCO monitor to that, and it calculated the stroke from that monitor. The other half of patients had continuous non-invasive arterial blood pressure monitoring from a CNAP module, and then we used the same LITCO algorithm to calculate the stroke volume. Yeah.
So, okay, thank you, Jakob. I mean, as a reader and also as editor, I would like to know how this idea came to your mind, and what was the journey behind the curtains of the publication?
Well, yeah, as I'm an anesthesiologist, and I think all anesthesiologists has had this experience when you are having to anesthetize a hemodynamically unstable patient, that sometimes just after in the minutes after induction, the signal from the pulse oximetry drops away or becomes very low, and so that's kind of the there's like this basic entry. What there's something happening here, and then we discovered that in fact our monitors at our OR was able to, just by clicking a few buttons, to show the PPI, and then we began to just play around with it, see what's going on. But we, in fact, the next thing we did was we had a study also with the Journal of Clinical Monitoring and Computing a couple of years back, where we looked at a smaller group of patients under general anesthesia, where we changed the preload by tilting the bed, and thus saw some changes to stroke volume and mean arterial pressure. And then we reversed and recruited preload to the patients to make the stroke volume come up again. And we saw that the PPI was able to track these changes. So we know there's something interesting going on. Then I thought, let's make it a little bit more difficult, because the thing is, when you are under general anesthesia, the PPI kind of reflects these changes, or changes in the PPI kind of reflects changes in these systemic hemodynamic parameters. My colleague, Professor Foss, he coined this phrase, the window to the heart. So when we can open by sympatholysis under general anesthesia, we can open the window and look into the systemic hemodynamic from the finger clamp. The opposite is applied when you are awake. The window is closed. In awake patients, it's what you can say that the main driver is the level of sympathetic activation. It's the sympathetic nervous system that determines the PPI. The higher the degree of sympathetic activation, the lower the PPI. And that's, of course, a bit difficult to work with, because it can be more benign causes like anxiety, fear, pain, but also severe causes like shock, sepsis, trauma that drives this sympathetic activation. But still, we thought there might be something going on when we go from this state of from, say, sympathetic nervous system dominated PPI to this more pulsatile input dominated PPI in this induction phase. But we knew we had to, bump up the volume of patients a little bit more, so we could describe like kind of a range of physiological or hemodynamic responses. Yeah.
Oh, thank you. I mean, what I found really interesting reading this study is that the study is per se quite simple, but simple doesn't mean trivial, So it's a straightforward idea. It's a simple concept, but at the same time, it's really, really interesting to read the results. And as an anesthesiologist, I mean, I feel that I can draw some really useful information out of it, even without the monitoring system itself. So it's I also congratulated with you, Jakob, talking in the phone during the preparation of this interview, because we as researchers, as anesthesiologists, we always try to find the fancy idea, the very wow effect research question. We also look for big grants, and we look for big studies, big RCTs. But this is a quite simple study with a lot of information out of it. So really, I feel I have to congratulate with you for these efforts.
Thank you. I also found it very satisfying to see that some of our ideas could come to fruition. We of course had kind of, based on what I said before, the hypothesis that there would be maybe a different types of response to induction, and that the PPI would be able to discriminate. We saw that in the quartile with the highest PPI, the PPI increased. That is kind of the normal response, and the response in healthy and younger patients, that the PPI does increase. And in this highest quartile, it increased by almost a factor of 3. And here we saw that the mean arterial pressure was reduced by only 25%, and the stroke volume was almost preserved at 86% of baseline value. Where in the other end of the spectrum, the PPI increased by half, and mean arterial pressure likewise decreased also by almost by half, and the stroke volume was down at 60% of baseline. So it seems like, and this is like analogous to this case I described earlier, where just the PPI just drops away. So there is something going on that makes it that we can say something about the physiology. And of course, as you said, it's interesting not only for me as a researcher, but also I think for everyone as a clinician, because this is not something very fancy. It's something that we have bedside, and in fact is, at least in theory, is available to everyone, everywhere in the perioperative setting, because, as I said, it is inherent to the photoplethysmography. So if you just can reach in and yank that signal out of your monitor, you have some extra monitoring at no extra cost. And that's what I think it's great, because we are short on staff, short on money, short on time, and this is something that gives us something for nothing. It's like the free lunch, Yes, so I think that's the most satisfying thing with this study. I think everybody can go out straight and use it. We also did, as in the article, we just tried to make it even more simple. So we said, what happens if the PPI decreases, and what happens if it increases? And in the 1/3 of the patients, in our selection, there was a decrease, and they also had a significantly more adverse hemodynamic response to induction than the other patients. So that would be the most easy way to go into this. Watch the PPI, and it changes almost beat to beat. So this is like this extra monitoring level between the intermittent non-invasive blood pressure monitoring and the invasive arterial cannula. That's it takes some time, and so you have this extra in between. I think that's nice.
Thank you. It's nice because in 2 episodes of these podcasts, we always go back to the same issue. That is, do the best for our patients, but to find a way of doing the best, discriminating between a bunch of monitoring systems, a lot of monitoring systems. Some of them are really expensive, new ones. So the commitment of our journal and in general of the anesthesia community is to work to find a better way of treating our patients without too much relying on the burden of costs, you know, in a time where the balance between costs and benefit need to be, it's our goal. So sustainability in every sense. So this is, it's really interesting. And what I was thinking is, at this point, what were the challenges in performing this study? So what were the challenges that you encountered from the idea to the implementation of such a study?
Challenging thing was I tried to calculate the sample size for this, but you know, soon it turned out this is impossible. Of course, there's quite a lot of data on, but not as much as you should think about that the hypotension upon induction of anesthesia, quite less about the changes in stroke volume. But about how the PPI performs, there's very close to nothing. There's one study that's been done before, a little bit a smaller study that showed that statistically the PPI increases and the arterial pressure decreases. I knew that beforehand, but I wanted to have enough patients because I thought there's something more, and that's what we finally, luckily, ended up showing. There's something more, that there's a different kind of response. There's this subset of patients where the PPI decreases, and these are the patients that are most hemodynamically unstable. And so it ended up, I just did like finger in the wind, we'll have 100 patients. And luckily it was enough, and we had kind of a statistic set. In fact, we had 111 patients, but then there was some missing data. So we had 107 that we could analyze, and that was lucky. But that was, you know, we just, because I have to, you know, make the protocol and just to say how much do you want. I said 100, so that's it.
So as a last question, I was interested in if you could suggest how this study could impact, in your opinion, the practice of anesthesiologists today, and if you have any perspective on what's next. So if you have in mind of you are, I mean, you can forecast if you see any development of this technique or for future studies.
Thank you. Well, first and foremost, I hope that our study can contribute to the more widespread use and knowledge of the PPI, as I mentioned before, because it is this very low-hanging fruit, because we have it all around. We just have to acknowledge we have it. Maybe, you know, play a bit with your monitor. Maybe get your medical technicians to get it out for you. But for very many of us and for our patients, it's readily available. So I hope we can bring some focus on that. When looking forward, what we are looking at is we use vasoconstriction quite a lot in a lot of our settings as a standard to many of our anesthetics. And of course, the idea is to counteract the sympatholysis and vasoplegia induced by the anesthetics that both alters the afterload and the preload. So, but we also know that, and we have all seen clinically, when using too high dose vasopressor, you can have some adverse effects on the patients. So what we are looking into, and think that the PPI can be maybe one parameter, is this level of safe vasoconstriction. And it seems that we use phenylephrine, and this is an alpha agonist, so it's just has no inotropic effect, but we see that when we use this, we will normally have an increase in the PPI and whether depending on the monitoring, we'll have of course increased arterial pressure, sometimes increase the stroke volume, but that would depend if we have stroke volume monitoring, and especially of course depend on whether the patient is preload dependent, because then if we can recruit preload with vasopressor, of course we can improve stroke volume and the PPI would increase. But at some level, and that can be in very unstable patients, you would give can come in this situation where you will apply too much vasopressor and have the adverse effects on organ perfusion. And of course, I would like to measure, end organ perfusion a lot of places on the patient, but that's not feasible. So I think this can be a canary in the coal mine, maybe for when is this vasopressor that we like, but when it's too much of a good thing. So that's where I think we're going. But I think in general, we just need to have more focus on this, because I'm really excited about what we have done in our institution, and also our anesthetic nurses use it a lot, and we can kind of also have a little bit of more. Sometimes hypotension is okay if the peripheral perfusion index is rather high. Of course, it's not the only thing, but you can have a little more cool with it. And sometimes if you have hypotension and no peripheral perfusion, you have to act immediately. So we use it in a lot of different ways. If I may add a little, one thing is we also use it sometimes when we have as an early warning of sympathetic activation. So also we can see sometimes when the PPI decreases and the mean arterial pressure, for example, increases. This is typically an early warning that maybe not the patient is about to wake up, but that there's the surgical stimulus is more intense than we thought, and then we have to especially give extra opioids or whatever. But also when you just look at it, you can see the patient is about to wake up when you have closed all the medicine, and then just the PPI will come up just like 30 seconds before or come down, of course, when the 30 seconds before the patient awakes. So there's a lot of things going on, but basically it's it's physiology, and that's always interesting, but you have to integrate all these different inputs that makes up the PPI.
Thank you. It's really interesting. I'm afraid our time is running out, so I would like to thank Jakob for being today with us, and I would ask to our followers and listeners to click follow on YouTube, Amazon Music, Spotify, and on all the platforms where they can follow us, because this is going to increase our engagement and it gives us the possibility to upload more contents on our podcast. So thank you, Jakob, once again. It was really nice to meet you.
Thank you for having me.